Welcome to The Explainer. Today, we are tackling a massive topic for your MRCP exam, one you absolutely have to know inside and out: stroke management.
Okay, let's put you right in the hot seat with a classic exam scenario. Your patient is brought in with sudden facial weakness. The clock is ticking. Every single minute matters, not just for the patient's brain, but for your score on the exam. So what's your next move?
So here's how we're going to break it down. We'll start with that initial assessment, figure out what and where the stroke is, talk about the crucial imaging decision, then dive into acute treatments, and finally, wrap up with post-stroke care. We're going to cover all the high-yield stuff you need. All right, let's jump in.
All right, Section 1, Initial Assessment. So first things first, in that high-pressure moment, how do you go from, I think this might be a stroke, to, I'm confident this is a stroke?
Now, everyone's heard of the FAST campaign, right? But for us as clinicians, the tool you really need to know for your exam is the Rogier score. It's the one recommended by the Royal College, and honestly, you've got to know it cold.
Okay, so let's walk through the Rogier score. It's actually pretty clever. Step 1, and this is absolutely critical, rule out low blood sugar. Hypoglycemia is a notorious stroke mimic, so you check that first. Then you start doing some math. You actually subtract points for things that make a stroke less likely, like a seizure or loss of consciousness, and you add points for the classic signs, that asymmetric weakness in the face, arm, or leg, plus any speech or vision problems. If you end up with a score greater than 0, boom, a stroke is very likely on the cards.
Okay, so you've used the Rogier score, and you're pretty sure you're dealing with a stroke. What's next? Well, now you've got to figure out what kind of stroke it is. And trust me, classification is a massive topic for the MRCP. This chart gives you a really nice, clean breakdown of the Oxford or Bamford classification. And what's interesting is how it's split. Look at that. Patchy, Lotchy, and Poachy each make up about a quarter of all strokes. The big one, the really severe one, the Tatchy or total anterior circulation infarct, is actually the least common. That's a good little fact to have in your back pocket.
All right, this table right here, this is gold. This is your high-yield cheat sheet for the exam. Examiners love, and I mean love, to ask questions that force you to know the difference between a Tashi and a Pashi. The key is knowing a Tashi has all 3 of those major features, while a Pashi only has 2. Seriously, burn this table into your brain.
And it doesn't stop with the Oxford classification. You also need to be able to pinpoint the artery involved based on the symptoms. This is classic exam fodder. A really common question will try to trip you up between an MCA and an ACA stroke. The dead giveaway? Remember, MCA is upper limb worse than lower. ACA is the opposite, lower limb worse than upper. Nail that down.
Okay, you've done your clinical assessment. You've classified it. Now comes the part that changes everything, the imaging. This scan is going to dictate your entire management plan.
So why the rush for a CT scan? And specifically, why a non-contrast CT? It comes down to one critical life or death question. Is it a clot or is it a bleed? You absolutely cannot give a clot-busting drug to someone with a brain hemorrhage. That would be a disaster. So this scan is your crucial safety check.
So what are you actually looking for on that CT? On the right, you see that bright white hyperdense area? That's blood. That's a hemorrhagic stroke. Easy to spot. Now, the one on the left, the ischemic stroke, can be a lot more subtle, especially early on. You might see some darkening, some low-density changes, but often the very first sign is what we call a hyperdense artery. That's literally the clot itself showing up as a bright spot in the vessel.
Okay, the CT is done. It's an ischemic stroke. Now we're at the climax of acute care. This is where we get into the really time-sensitive stuff that can literally save brain tissue.
Right. Before you can even think about thrombolysis, you have to get the blood pressure under control. And here's a number you just have to memorize: 185 over 110. The BP has to be at or below this target. Why? Because if it's too high, you dramatically increase the risk of the ischemic stroke turning into a hemorrhagic one. So BP control first. Okay, if there's one slide you screenshot, this is it. These time windows are pure exam gold. You have to know the standard 4.5-hour window for thrombolysis with alteplase. But don't stop there. You also need to know the extended windows, up to 6 hours for a thrombectomy in the front of the brain, and even up to 24 hours in some cases, especially for those wake-up strokes where you use advanced imaging to find salvageable brain tissue.
And just as important as knowing when to give thrombolysis is knowing when not to. You can bet you'll get a question on contraindications. The absolute ones are non-negotiable. A previous brain bleed? No way.
A major stroke in the last 3 months? Absolutely not. A seizure right at the start of this stroke? That's another big red flag. Get familiar with this list.
All right, so the drama of the emergency room is over. The patient is on the ward. But our job is far from done. Now we shift gears to stabilization and, crucially, preventing this from ever happening again.
So, what are your immediate priorities on the ward? It's all about supportive care. You're keeping an eye on their glucose, making sure they're hydrated, keeping their oxygen levels up. But here are 2 really high-yield points for your exam. First, as soon as that CT scan has ruled out a bleed, you give them 300 milligrams of aspirin, stat. And second, they are strictly nil by mouth. Do not give them anything to eat or drink until they've had a proper swallow screen. Aspiration pneumonia is a serious and preventable complication. And here's another magic number for you. For secondary prevention, the target is a cholesterol level of 3.5. If their cholesterol is above 3.5 millimoles per liter, they need a high-intensity statin. We usually wait about 48 hours to start it, just to be safe, but it's a key part of their long-term management. Now, let's talk about long-term prevention, and this is where you need to be up to date with the latest NICE guidelines. Here's a big one. Clopidogrel is now first line, not aspirin. That's a change from older practice. And another classic exam trap. If your patient has AF, you don't just start them on anticoagulation right away. You typically wait about 2 weeks after the stroke. That's a really important detail.
So let's just wrap this up. From that initial Rosier score all the way to thinking about carotid endarterectomy, mastering this entire pathway isn't just about good clinical practice. It's about mastering a core, and I mean core, part of the MRCP exam.
And with that, we're at the end of our high-yield review. To make sure this all sticks, we'll leave you with one final question to chew on. This is exactly the kind of multi-step problem you'll see on the exam. So, have a think about it. Thanks for joining us.